He's tried to light his own candle some other way. See now your sister, she's been robbed and lied to. Still holds a candle without a flame. To the darkness, seek out the lonely, sad and lonely. For all to see, take your candle, go light your world. Take your candle and go light your world. We are a family whose hearts are blazing. Let's raise our candles and light up the sky. Praying to God in the name of Jesus. Make us say beacon in darkest times. Run to this, seek out the helpless, save them all. For all to see, take your candle and go light your to the dark, to the dark, say to see, take your candle, light your world, take your candle, go light your world.
Next, we are honored to have Ms. Subha Maurya, student of MSc Nursing first year, who will discuss about ethics of palliative care.
Good afternoon to all. Good afternoon, respected Vice Principal Ma'am, all teachers and students. Myself, Shubham Maurya, I am from MSc Nursing first year. So, today I will discuss about seminar. My topic is ethics of palliative care. ठीक है. First one, ethics in palliative care. ठीक है. First one I will discuss historical perspective of Indian palliative care. We all believe that palliative care is a foreign idea, but the truth is ancient India during the period of Ashoka and Mauryan Empire had 7 institutions of healthcare. In that, one of the institution is characteristics resemble to the palliative care, which has norms, ethics, and principles to carry out those services. Means हमें ये था कि ये हमारा क्या है, ओल्ड वन है, ठीक है. मीन्स क्या है कि जो फॉरेन आइडियाज है, जो हमारा एथिक्स है, ना। ये था कि ये ओल्ड मतलब फॉरेन आइडियाज है, बट क्या है, नहीं, ये हमारा ओल्ड आइडियाज है, ये इंडियन, ठीक है। जैसे कि ड्यूरिंग टाइम पीरियड ऑफ अशोका, ओल्ड थिंग्स है, हम आइडिया हर जगह हम क्या करते हैं, एथिक्स को फॉलो करते हैं, एक नॉर्म्स एंड रूल्स को फॉलो करते हैं, ठीक है। हमें ये था कि ये अभी तक ये पता था कि ये हमने कहाँ से लिया था, फॉरेन आइडिया से, बट ये हमारे यहाँ भी इंडिया में भी ये फॉलो हो रहे हैं, ठीक है, क्योंकि विदाउट एथिक्स नो एनीथिंग ना। तो क्या था कि हम एथिक्स हर जगह यूज करते हैं। फिर नेक्स्ट वन क्या है, अ मैन कैन फेल बट नाउ हिज आइडियाज, सो फॉर अस इट्स एन एनसेट आइडियाज विच वी आर अपडेटिंग नाउ, ठीक है। डे बाय डे क्या होता है, ये अपडेट होता है। हम आइडियाज, हमारे जो एथिक्स होते हैं वो सेम होते हैं, बट क्या होता है कि हमें नीड होती है कि अपडेट करने के लिए, क्योंकि हमारे जो टाइम्स हैं, जो हमारा अभी न्यू टाइम्स चल रहा है ना, जनरेशन के अकॉर्डिंग हमें क्या करना है, उसमें चेंजेस लाने होते हैं ना। तो उसी तरह कुछ एथिक्स, एज एग्जांपल ले लो कि पहले क्या होता था कि जब हम चाइल्ड मैरिज होती थी ना, चाइल्ड मैरिज होती थी, बट अभी क्या है कि वो हमने क्या कुछ चीजें चेंज की हैं ना। हम क्या कर रहे हैं कि अभी एक टाइम लिमिट दिया गया है, एक एज दी गई है जिसमें 18 प्लस होना चाहिए, ठीक है, मैरिज के लिए। तो वो हमने क्या किया, अपडेट ही तो किया ना। तो सेम चीजें क्या है, एथिक्स में हमें क्या करना है, सेम रहता है, बट हमें क्या है, चीजों को अपडेट करना होता है, ठीक है। नेक्स्ट वन, मेडिकल एथिक्स इज अ सिस्टम ऑफ मोरल प्रिंसिपल दैट अप्लाई वैल्यूज एंड जजमेंट टू द प्रैक्टिस ऑफ मेडिसिन, ठीक है। इसमें क्या होता है, मेडिकल एथिक्स इज अ सिस्टम ऑफ मोरल प्रिंसिपल्स। एथिक्स क्या होता है, वो एक सिस्टमैटिक वे होता है जिसमें क्या है, मोरल प्रिंसिपल ना, हम क्या करते हैं, प्रिंसिपल्स को फॉलो करते हैं, रूल्स रेगुलेशंस को फॉलो करते हैं, ठीक है। नेक्स्ट वन, ethics in palliative care introduction. Ethics is a set of moral principles in concern with the rightness and wrongness of human behavior and which guide your conduct relation to others. Means जो हमारा ethics क्या है, ये set of moral principle है in concern with the rightness, हमें ये identify करवाता है कि क्या ये right है या फिर wrong है, ठीक है, जो हमारा एथिक्स होता है। नेक्स्ट वन क्या है, द पर्पज ऑफ द सेक्शन इज टू असिस्ट द प्रोफेशनल टू बी एबल टू एनालाइज अ क्लिनिकल इशू फ्रॉम अ एथिकल पॉइंट ऑफ व्यू एंड टू टेक डिसीजन ऑन हाउ बेस्ट टू मैनेज द कॉम्प्लेक्स प्रॉब्लम रिलेटेड टू अ पेशेंट। जो हमारा मेन पर्पज क्या होता है एथिक्स का मेडिकल में, ठीक है, इसमें क्या होता है कि हमें सबसे पहले क्या है, जो भी क्लिनिकल कुछ भी कंडीशन होती है, हम क्या करते हैं, एनालाइज करते हैं, ठीक है, और क्या करते हैं, जो ट्रीटमेंट होता है, यू टेक डिसीजन, जो भी ट्रीटमेंट है, पहले हम डायग्नोसिस करते हैं, फिर ट्रीटमेंट, गो थ्रू ट्रीटमेंट ना, ट्रीटमेंट के लिए तब जाते हैं। तो हमें क्या करना है, फिर ये क्या करता है, हेल्प करता है डिसीजन लेने में, अंडरस्टैंड। नेक्स्ट वन, द क्लिनिकल जजमेंट आर based on value held by the patient, the family and doctors। इसमें क्या होता है कि ये हमारा बेस्ड होता है कि इसमें पेशेंट, द फैमिली मेंबर्स, पेशेंट पे हमें कुछ भी चीजें करते हैं तो इन्वॉल्व करना किसको, पेशेंट और फैमिली को। नेक्स्ट वन, ठीक है, जो डॉक्टर्स जो इन्वॉल्व होते हैं, फर्स्ट हमें कुछ भी करने से पहले हमें किसको इन्फॉर्म करना होता है, पेशेंट को एंड द फैमिली मेंबर्स को, ठीक है, क्योंकि ये हमारा एक एथिक्स है। हमें ये नहीं है कि कुछ भी चीजें हमें उनके रिगार्डिंग हमें पता चली है डायग्नोसिस के थ्रू तो हमें क्या करना है, उन्हें कुछ भी नहीं बताना, ऐसा नहीं है। हमें क्या करना है, उन्हें पहले ये सारी चीजें शेयर करनी। नेक्स्ट वन क्या है, इन सिचुएशन वेयर देयर इज क्लियर राइट एंड क्लियर रॉन्ग आंसर डिसीजन मेकिंग इज इजी। इन इसमें क्या होता है कि जो क्लियर, जो सिचुएशन वेयर देयर इज क्लियर राइट और रॉन्ग, हमें क्या होता है कि कुछ भी डिसीजन लेने में इजी होता है, राइट है या फिर रॉन्ग है। नेक्स्ट वन, देयर में विल बी डिफरेंस इन व्यू एंड ऑलमोस्ट ऑलवेज देयर विल बी अनसर्टेनिटी। इसमें क्या होता है, डिफरेंट व्यूज होते हैं, डिफरेंट पर्संस के होते हैं। नेक्स्ट वन, एंड ऑलमोस्ट always there will be uncertainty, changes होते रहते हैं. Practically speaking, the money in clinical situation can always lead to success medical care. Sometimes more than one option may look right, leading to dilemmas and difficulties. इसमें क्या होता है कि हमारे पास जो गोल्स होते हैं, कभी कभी गोल्स को अचीव करने के लिए बहुत सारे वे होते हैं, ठीक है. तो वहां पे क्या होता है, हमें ये चूज करने में प्रॉब्लम होती है कि क्या कौन सा वे हम चूज करें. तो वहां पे हमें क्या होगी, डिफिकल्टीज होगी ना, होगी. नेक्स्ट लाइन ये लिखा, लास्ट लाइन, समथिंग मोर देन वन ऑप्शन में लुक राइट, लीडिंग टू dilemmas and difficulties. Okay, understand? Next one, code of ethics. In some cases, the perceived important 12 have been codified and written down. The most famous of these in the Hippocrates Oath, which set out some of the ethical principles which the doctor should follow. ठीक है, इसमें क्या होता है, कुछ इंपॉर्टेंट 12 होते हैं जो हम क्या करते हैं, कोडिफाई करते हैं या फिर राइट डाउन करते हैं. नेक्स्ट वन क्या है कि जैसे हमारे में नाइटिंगेल सोच ना हम लेते हैं, उनके थ्रू कुछ हमारे रूल्स रेगुलेशंस होंगे, कुछ हमारे एथिक्स होंगे. उसी तरीके से सेम हिप्पोक्रेट्स, ये क्या है, फादर ऑफ मेडिसिन. ठीक है, जो हमारे हिप्पोक्रेट्स है वो फादर ऑफ मेडिसिन है. इसमें क्या होता है, उनके भी कुछ एथिकल कोड है जो सेट है, और वो क्या करते हैं, डॉक्टर्स जो हमारे होते हैं वो फॉलो करते हैं. ठीक है, जो भी नॉर्म्स है. नेक्स्ट वन क्या है, देयर आर मेनी अदर्स इंक्लूडिंग द Palliative Declaration of Human Rights. These provide useful checkups and promotes from those practicing palliative medicine. सेम चीजें क्या है कि कुछ भी चीजें अगर हम डिक्लेयर करते हैं, ठीक है, इनके थ्रू यही बताया गया है कि जो भी डिक्लेरेशन होता है, जो भी राइट्स ऑफ नॉर्म्स होते हैं या फिर एथिकल होते हैं, सेम चीजें हम क्या करते हैं, फॉलो करते हैं. नेक्स्ट वन, सम की एथिकल कॉन्सेप्ट. ठीक है, तो फर्स्ट पॉइंट है अ ड्यूटी टू एलिवेट सफरिंग. हमारी जो नर्सेस की रिस्पॉन्सिबिलिटी, जो रोल्स होते हैं, जो ड्यूटी होती है, वो क्या होती है कि हमें क्या करना है कि पेशेंट को जो भी कंडीशन है उससे क्या करना है, ट्रीट करना है. फर्स्ट हमारा क्या होता है, अ ड्यूटी एलिवेट सफरिंग. कोई भी पर्सन है किसी भी कंडीशन से सफर कर रहा है तो हमें क्या करना है, ट्रीट करना है. ठीक है, तो इसमें दिस इज अ ऑब्वियस कॉन्सेप्ट, बट लाइक ऑल सच कॉन्सेप्ट नॉट एज सिंपल it seems. Of course we should elevate suffering, but at what cost, either quality of life or financial. Have we failed in our duty? हमें ये पता है कि हमें क्या करना होता है. ठीक है, हमें क्या करना होता है कि जो हमारी ड्यूटी, जो हमारी रिस्पॉन्सिबिलिटी है, हमें पर्सन कोई भी कंडीशन से सफर कर रहा है तो हमें ट्रीट करना है. बट हम क्या हमारे साथ क्या हो रहा है कि हम वहां पे फेल हो रहे हैं ना. नेक्स्ट वन क्या है, रिस्पेक्ट फॉर पर्सन. हमें पर्सन्स को क्या करना है, रिस्पेक्ट करना है. फर्स्ट, जिसमें क्या, वी शुड कंसीडर द पेशेंट एंड हिज डिग्निटी इन द क्लिनिकल केयर सेटिंग. हमें क्या करना है, पेशेंट से एक डिग्निटी मेंटेन करके रखनी है, और क्लिनिकल एरिया में, क्लिनिकल सेटिंग्स में, दिस आवर कम्युनिकेशन विद हिम, हिज फैमिली, ट्रीटिंग हिम विद रिस्पेक्ट एंड courtesy and respective the patient wishes even if they differ from own. हमें क्या करना है कि अगर एक क्लिनिकल एरिया में हमें एक डिग्निटी मेंटेन करके रखनी है, कम्युनिकेशन करना है, तो वहां पे क्या करना है, पेशेंट की रिस्पेक्ट करनी है, फैमिली मेंबर्स की रिस्पेक्ट करनी है, और एक डिग्निटी को मेंटेन करके रखना है. समटाइम क्या होता है, उनके कल्चर्स के अकॉर्डिंग हमें उन्हें कम्युनिकेट करना होता है ना, उनके कल्चर्स का भी हमें रिस्पेक्ट देनी होती है. हमें नहीं पसंद है वो बात अलग की है, बट हमें ये चीजें वहां पे, ये नहीं कि हमें नहीं पसंद है हम नहीं कर सकते, हमें करना होता है वहां पे. ठीक है, उनके अकॉर्डिंग, क्योंकि फर्स्ट क्या है हमारा, रिस्पेक्ट. फर्स्ट पॉइंट ऑफ व्यू रिस्पेक्ट होता है. ठीक है, नेक्स्ट वन, एथिक्स इन पैलिएटिव केयर, कोर एथिकल प्रिंसिपल. फर्स्ट वन, ऑटोनॉमी. ठीक है, ऑटोनॉमी में क्या है, रिस्पेक्ट अ पेशेंट राइट टू मेक इन्फॉर्म डिसीजन अबाउट दियर केयर। ऑटोनॉमी मतलब सेल्फ डिपेंडेंट, ठीक। इसमें क्या होता है, रिस्पेक्ट पेशेंट राइट टू मेक इन्फॉर्म डिसीजन अबाउट दियर केयर। हमें कुछ भी केयर प्रोवाइड करते हैं तो हमें फर्स्ट क्या करना होता है, डिपेंडेंटली उन्हें इन्फॉर्म करना होता है, ठीक है। नेक्स्ट वन क्या है, इंश्योर अ पेशेंट प्रेफरेंस एंड वैल्यू गाइड देयर ट्रीटमेंट प्लान। नेक्स्ट है, every human being of adult year and sound mind has a right to determine what shall be done with his own body। every person में ये उनके राइट्स होते हैं कि उनके बॉडी के साथ क्या हो रहा है उन्हें ये पता होना चाहिए। किसके अकॉर्डिंग है ये, जस्टिस बेंजामिन कॉर्डेजो इन 1914 में उन्होंने ये थॉट्स दिए थे। नेक्स्ट वन, नॉन मॉलफिशियंस, इसमें क्या, अवॉइड हार्म एंड अननेसेसरी सफरिंग फॉर अ पेशेंट। हमें क्या करना है, अननेसेसरी पेशेंट को हार्म नहीं करना है, ठीक है। हमें ये सारी चीजें अवॉइड करनी है, उनके अकॉर्डिंग जो उनके लिए बेनिफिट है वो सारी चीजें हमें करनी होती है उनके केयर के टाइम। नेक्स्ट पॉइंट, इंश्योर इंटरवेंशन डोंट आउटवे पोटेंशियल बेनिफिट्स। नेक्स्ट वन, बेनिफिशियंस, इसमें एक्ट इन द बेस्ट इंटरेस्ट ऑफ अ पेशेंट वेलबींग। हमें क्वालिटी ऑफ केयर प्रोवाइड करनी होती है, जो भी पर्सन है हमें, जो भी पेशेंट है उन्हें क्वालिटी ऑफ केयर प्रोवाइड करनी होती है। नेक्स्ट वन, प्रोवाइड इंटरवेंशन टू इम्प्रूव अ पेशेंट क्वालिटी ऑफ लाइफ। जो भी हम इंटरवेंशन कर रहे हैं उनके अकॉर्डिंग क्या है कि उनकी लाइफ में वो इम्प्रूवमेंट हो, उनकी क्वालिटी ऑफ लाइफ इम्प्रूवमेंट। नेक्स्ट वन, जस्टिस इंश्योर इक्विटेबल एक्सेस टू केयर फॉर ऑल पेशेंट। हमें ये इंश्योर होना है कि हम इक्विटेबल, इक्वली, हमें क्या करना है कि यहाँ पे डिस्क्रिमिनेट नहीं करना है, हमें सेम चीजें, सेम केयर सारे पेशेंट को प्रोवाइड करनी है, उनके जेंडर के अकॉर्डिंग, उनके एज के अकॉर्डिंग, उनके सेक्स के अकॉर्डिंग, उनके रेस के अकॉर्डिंग। ये हमें इस तरीके से क्या करना, डिस्क्रिमिनेट नहीं करना, उनके अकॉर्डिंग ही हमें उनकी केयर करनी होती है। प्रोवाइड नॉन डिस्क्रिमिनेटेड केयर टू एड्रेस पेशेंट नीड। हमें क्या करना है, डिस्क्रिमिनेट नहीं करना है, उनके नीड के अकॉर्डिंग केयर प्रोवाइड करनी है। नेक्स्ट वन, medical professional obligation on palliative care, some aspects diagnosis। फर्स्ट वन, हमें क्या करना है, डायग्नोसिस करनी है कि क्या कंडीशन है। नेक्स्ट वन, डिस्क्लोजर, क्या करना है, डिस्क्लोज करना, ओपन करना है कि कंडीशन क्या है उनकी। ये नहीं कि हमने डायग्नोस किया और हमें अपने पास तक ही रखना है, ऐसा नहीं होता। हमें क्या करना, पेशेंट को वो सारी इंफॉर्मेशन बतानी होती है कि ये कंडीशन पर्सन को है। नेक्स्ट वन क्या करना है, डिसीजनल अथॉरिटी। हमें क्या करनी है कि उनके पास जो भी डिसीजन लेना है वो ले सकते हैं, हमें उन्हें फोर्सफुली नहीं करना होता है, ठीक है, कि आप ये डिसीजन है उनके अकॉर्डिंग, अगर लग रहा है कि हमें यहाँ ट्रीटमेंट करवाना है तो बेटर है, नहीं तो अनदर हॉस्पिटल वो चूज कर सकते हैं। नेक्स्ट वन क्या है, एक्सेप्टेंस ऑफ एंड डिसीजन टू फॉरगो ट्रीटमेंट। हमें क्या करना है, एक्सेप्ट करना है और उनके डिसीजन में हेल्प करनी है, वो कहीं अदर प्लेसेस भी अपना ट्रीटमेंट करवा सकते हैं। नेक्स्ट वन, बेनिफिट्स वर्सेस अफेक्ट एंड टोटल केयर। फर्स्ट वन, अफेक्ट is a response to an intervention limited to improvement in investigation parameters or function of an organ. Example, serum creatinine decreasing from 6 mg to 3.7 mg%, or urine output increasing from 100 ml to 500 ml. Effect, for example, second one, benefits, for example ले लो, first one effect, हमारी बॉडी को कुछ भी अगर चीजें इफेक्ट हो रही हैं, जैसे हमने क्या किया, इम्प्रूवमेंट इन्वेस्टिगेशन पैरामीटर्स, उसके थ्रू हमें क्या पता चला कि कंडीशन क्रिएट हुई है। फिर हमें क्या करना है कि जो इफेक्ट हो रहा, अगर हम कुछ भी चीजें अप्लाई कर रहे हैं तो पर्सन ऑब्वियसली बात है इरिटेटेड होगा, अफेक्ट तो हो रहा है ना। नेक्स्ट वन क्या है, बेनिफिट। अफेक्ट होने के बाद फिर हमारा क्या है, बेनिफिट होगा, क्योंकि कुछ भी चीजें हम अप्लाई कर रहे हैं तो फर्स्ट अफेक्ट होगा, लेकिन वो हमारे बेनिफिट के लिए ही हम क्या कर रहे हैं, अप्लाई कर रहे हैं। इज द रिस्पॉन्स विच टाइप पेशेंट हैज द कैपेसिटी टू appreciate an unconscious ventilated patient becoming orientated and ambulant। बेनिफिट्स हो रहा ना, क्योंकि हमने क्या डायग्नोसिस किया, डायग्नोसिस कुछ भी मशीनरी यूज हमने किया वो हमें इफेक्ट करा, लेकिन बेनिफिट ये है कि आइडेंटिफाई हुआ कि ये कंडीशन के लिए ये कंडीशन हमारे में हुई है। नेक्स्ट वन क्या है, total care। goal of medical care is to achieve a benefit above a certain minimal threshold। total care is care that fail to achieve that benefits। इसमें क्या है कि जो गोल्स, एक पार्टिकुलर हमारा गोल फिक्स होता है कि कुछ भी करने से पहले फर्स्ट वन क्या है कि जैसे हमने पेशेंट एक लिया, पेशेंट में ये है कि हमें क्या करना है, उसे हेल्दी, उसका क्या जो हेल्थ है उसे प्रमोट करना है, प्रमोट करना है। बट क्या है कि यहाँ पे क्या फेल हो रहा है, हम गोल को अपने अचीव नहीं कर पाते हैं। इस केयर में क्या होता है कि गोल्स को हम अचीव नहीं कर पाते, पार्टिकुलरली गोल हम रखते हैं ना कुछ भी करने से पहले, तो ये क्या हो रहा है, फेल हो रहा है। ठीक है, इसको हम क्या बोलेंगे, टोटल केयर। नेक्स्ट वन, व्हाट इज पोलेस्ट। न्यू थिंग्स है, फिजिशियन ऑर्डर फॉर लाइफ सस्टेनिंग ट्रीटमेंट। दिस इज द न्यू systematization in palliative care according to prioritization of the care terminal ill patient, added being with a process। next one, a conversation। third one, a medical order। first one हम प्लान करते हैं, प्लानिंग होती है ना कुछ भी करने से पहले, पार्ट ऑफ एडवांस केयर प्लानिंग रिकॉग्नाइज्ड थ्रू अ नेशनल पैराडिगम, स्टेट प्रोग्राम एंड मेडिकल ऑर्डर कंप्लीशन। नेक्स्ट वन क्या है, अब कन्वर्सेशन। फर्स्ट वन हमने क्या किया, प्लान किया। नेक्स्ट वन क्या है, अब कन्वर्सेशन। हम क्या करते हैं, पेशेंट से कन्वर्सेट करते हैं कि क्या रिस्क है, क्या बेनिफिट है, क्या बर्डन है। ठीक है, आउटकम्स पेशेंट प्रेफरेंस। नेक्स्ट वन क्या, अ मेडिकल ऑर्डर, अ फॉर्म दैट ट्रेवल्स अक्रॉस वेरियस केयर सेटिंग्स। बहुत एक फॉर्म होता है किसके थ्रू, पॉलिस्ट। पॉलिस्ट जो है वो उसमें क्या होता है, फॉर्म हमें फिल करना होता है और वो वेरियस सेटिंग से होके फिर गुजरता है। ठीक है, जिसमें क्या बहुत सारी चीजें हमें क्या करनी होती है, फिल करनी होती है। नेक्स्ट वन, रिसर्च रिलेटेड टू कोड ऑफ एथिक्स। ऑन 2 February 2015, a study was conducted on researcher prescription of ethical guidelines and code of ethics by Bensett, Jansen and all। बहुत सारे ऐसे रिसर्चर्स हैं, वहां पे लास्ट वन मैंने एट ऑल किया है, उन्होंने ये स्टडी की थी। द समरी ऑफ द रिसर्च क्लियरली स्टेट दैट 67% of the researcher who undergoing research not following the codes। 67 क्या उन्होंने रिसर्च किया वो क्या है कि कोड्स को फॉलो नहीं करते हैं। नेक्स्ट वन, एथिक्स एंड आल्सो नॉट फॉलोइंग द एथिकल कमिटी एडवाइज एंड 7% ऑफ द रिसर्चर आर अनअवेयर ऑफ एथिकल कंसिडरेशन। 7% जो क्या है वो अनअवेयर है। नेक्स्ट वन, दिस सो देयर आर लॉस्ट ऑफ study to be conducted, lots of study to be conducted to address this issue। जहां भी हमें रिसर्च करना है वहां पे ये नीड, मतलब ये हमें नीड होती है कि बहुत सारी स्टडी को कंडक्ट करना है, क्योंकि क्या है कुछ पर्सन जो है वो 67 वो क्या है यहाँ पे वो फॉलो नहीं कर रहे हैं एथिक्स को। नेक्स्ट वन क्या है, वो क्या कर रहे हैं, अनअवेयर है। 7% है जो वो अनअवेयर है। और फिर हमें क्या करना है, इन तीनों को वो करना है। कंप्लीट करने के बाद फिर हमें नीचे ये करना है कि उस एरिया में हमें बहुत सारी, मतलब बहुत सारे स्टडी को कंडक्ट करने रिसर्च के। क्योंकि आइडेंटिफाई नहीं हो रहा है कि क्या वो कोड्स को फॉलो कर रहे हैं, एथिक्स को फॉलो कर रहे हैं या फिर नहीं। नेक्स्ट वन क्या है, एंड नॉट retaining the research setting and the population participated in the research because I know the code of ethics. हम ethics follow कर रहे हैं, ठीक है। Next one, conclusion. The framework adopted by any individual, be it patient, family member, professional, may vary on these factor, duties and principles. From the brief discussion, certain conclusion can be drawn. Second point, there are many frameworks for ethical decision making. Third point, decision may have to be taken at time in the face of uncertainty and thus judgment will be required. So there is a sample scope of disagreement on what to do. Fourth point, there can be no right or wrong approach, just difference between different bases held by individuals. Next, summary. So, first one, I'll discuss historical perspective of Indian palliative care. Second one, ethics in palliative care. Third one, code of ethics. Fourth, some key ethical concepts. And next one, core ethical principles. Next, benefit versus effect and total care. Next, what is polished. And last one, research related to code of ethics. Understand? Thank you.
Thank you, Ms. Subham, for acknowledging us about the ethics of palliative care. Moving forward, I would like to call Ms. Piyush, student of MSc Nursing second year, going to discuss about palliative care in vulnerable group. Put your hands together for Ms. Piyush.
Hello and good afternoon to all. I am Piyush Yadav from MSc Nursing second year, and my topic is palliative care in vulnerable groups. Everyone know the palliative care. Everyone is going to define the palliative care from the morning to now. So everyone have that idea. And what is palliative care and which patient we are giving palliative care? Okay. If we are going to talk about life, then everyone is very concerned about their life or age. Okay. So if I am going to start my introduction of palliative care in vulnerable group, then I can start my introduction by Mary Oliver Bird. She is a very famous poet, and she is suffering from cancer, lymphoma cancer. On that time, she mentioned these words for life. Like, we are thinking, no, after dying, what will be happen? So, does everything die at last and or too soon? Tell me. What is you plan to do with your one and wild and precious life? Everyone have their plans about their life. So she is asking these questions, and maybe our younger generation doesn't have these things to know, and they are not wearing with these words. So if we are going with the palliative care in vulnerable groups are that groups who are negligencing from the society, and maybe in our society we are not going to focus on that persons or that groups. So it is main goal is to relieve patient of the pain, discomfort and mental and physical strain that came with a serious illness. Palliative care is only belonging to save the patient or make comfort with the patient. So first of all, we have to know the things. Vulnerable group. What do you mean by vulnerable group? That group, if we are going with the WHO definition, that definition is given by the WHO for health. They simply mention it is straight with the physical, mental, social, and spiritual things. Like if we are healthy, then physically, mentally, and socially, if we are healthy, then we consider as a healthy person. If it is not there, then we are not healthy. We are suffering from any disease conditions or any illness. So vulnerable groups, that groups, they are belonging with that groups, disadvantaged person we are considering in our society. So they are physically, mentally and socially disadvantaged persons who may be unable to meet their basic needs and may therefore require specific assistance. It means that the persons are who are disadvantaged in our society, they are not accepted by our society, that persons are coming in vulnerable group. Vulnerable group, if you are going to say that what are the form, maybe we are considering everything in types, like vulnerable groups, if we are saying that Sophia, she is giving one general in says general that considered two vulnerability forms are there. First, inherited vulnerability and second, pathogenetic vulnerability. If we are going with the first, inherent vulnerability, uh, you know the things like inherent always state genetically. Any disease conditions is coming genetically, then we consider in inherent or genetic. So vulnerability, that is belonging with any family or any person, that disability is coming from the family, mother or anyone. Like any patient is there, she is suffering from HIV, then we are proving that we are considering that the baby is maybe suffer from, in future they have HIV or AIDS. So in that conditions, that person's uh, that person needs some materials to make their life smooth, or we can say for a long life. Then if we are giving that materials, like how we can take that patient, how we can treat that patient, so that is coming in inherited vulnerability. That group is also there, and during that stage, that the patient's course of disease, the situation when living with the life like limiting illness is characterized by weak physical conditions and bodies decay, especially during the dying phases. Second, pathogenic vulnerability. Some persons are unable to perform their life uh, daily life functions, like that persons are disabled, or maybe they are dysfunctional according to any issue, or we can say disease conditions. If they are suffering, they are coming in pathogenic vulnerability. Pathogenic vulnerability means they are already suffering from any disease. Pathogenic vulnerability may be granted by moral dysfunction in personal and social relationship characterized by the disrespect. We can say if any person is suffering from any disease conditions from the chronic periods of time, we can say, then the persons who are dealing with that persons, like nurses or we can say family members also, they are not giving respect to that person, or prejudice. We can say that person is suffering from prejudice, abuse or social political situations. Our society is also not accepting that person in our society. So that vulnerability, then pathogenic vulnerability belonging with that persons, that persons have injustice, maybe he is feeling like that. So that person is coming in pathogenic vulnerability. what are the vulnerable groups are there? If we are talking about vulnerable groups, then any criteria is there enough for that. So we are considered five categories, or you can say types for vulnerable groups. First category is that age and developmental stage. Second, gender and sexual identities. And third, pre-existing chronic conditions, persons with disabilities, or and marginalizations group in the community. We can say that if groups are there, then the persons who are suffering with that group, then we have to give that type of palliative care to that kind of person. If we are going with the stage and development of developmental stage, or age and developmental stage, if we are thinking about the age or developmental stage, one thing is coming in our mind: two stages of our life who need most care and support. First, after the birth, a baby need too much care and support with maybe by her family or by her mother. And at last of the life, we can say elderly person need more needs care and support. So that persons we are considering in age and developmental stage. With the clear concept, we are going with the next, gender and sexual identities. If gender and sexual, we are talking about gender and sexual identities in our society, too much persons are belonging with that identities. They are not physically, like we can say, we considering a policies or committee is there in our society, lgsb sorry lgbt. Okay, you know, the things are going on in our society and they are belonging with this identities. So if they are feeling like that, we have to treat that committee what they want. That's why we have to consider these things also, because these committees are more capable to say their things. So we have a communication skill to talk with that persons. Gender and sexual identities, gender and sexual minority people is particular trans and non-binary people. It's mean like that persons, if I am a girl and I am not feeling that, in inner side I am not feeling that I am a girl, it's mean that that person is have to uh, treat me as a boy if I am feeling that I am a boy. Okay, and any boy is suffering from these conditions, or he is feeling that he is not a boy, so we can treat them like what he wants. So it is also like a psychological support, or like that we can treat him. Next is pre-existing chronic condition. Pre-existing chronic condition, we know that some persons are suffering from chronic conditions and chronic disease, we can say, like asthma or HIV, or that diabetes is there in our society. Too much chronic conditions are present, that persons are suffering for that, then we have to care a long time of period for that. So we have to we have to know about how we have to deal with that persons. Examples that some pre-existing chronic conditions included diabetes, hypertension, asthma, arthritis. More are there that in our society the persons are suffering from these conditions, and we have to focus on this also. Next, person with disabilities. In palliative care, we are focusing only with the support and care of that person. So person with disabilities, it's mean like maybe that person is not able to do their own works physically, essentially we can say that that impairment is present in that person, then we can treat that person according to us or according to him. Marginalization groups in our community. Marginalization groups means that groups that are neglected by our society. If any group are there and they are thinking that we are not important for the society, that they are also not involving in any activity that we are performing in treatment or anything. So we have to include that persons in our palliative care also. Palliative care for vulnerable groups. What are the things we know, that what is palliative care and what are the vulnerable groups, or vulnerable persons are coming vulnerable groups. So according to that, we can we have to know the things what we have to give that person. First, elderly peoples. What are the things they need? If we are talking about any elderly person, that physical vulnerabilities are very important. Like any elder person is there, he is suffering for arthritis or any other thing, so we have to give the palliative care like that. Physically, say we can say psychological support that person. We can in our society we are able to know that the person who are elder, they are uh, make themselves like a child, so we have to support that person psychologically. If they are dealing with that things, then we have to give that emotions and psychological support to the that person. Family involvement, that in our society we are dealing with that situations where the elderly persons are not belonging with the family, they neglect that person or they are not willing with that person. So family involvement is also important. Like a child, a elder person also need family. Next, child pediatric palliative care. If we are talking about child or pediatric palliative care, in that care, developmental consideration is very important. In the starting of the stage of our life, if we are a small child or we can say in our family also, then consideration means according to the stage, according to the life stage, we have to consider that that child with a good habits, with a things that he have to know or she have to know. Then second thing is family centered care. Family centered means if any child is there in our family, we have to center, we have to see the activities, their behavior, their the things, what how they are performing, how they are behaving, how the things they are going to do, or what are the things they are going to learn. Next, communication. Every child need communication. If any person is there or any child is there in our family, then that family member have to communicate with that child. Why? They can share their thoughts, they can know what are the things, what are the difficulties they are facing. If we are going to communicate with them, then we can know easily. Third, people with disabilities. Developmental consideration is also there, like the stage of the disease condition or disabilities is going on, that developmental stage considered. Like if any person is dealing with any disabilities, so developmental stage is there in that disease condition also. So according to that, we have to treat that patient. Family centered care, that persons who are disabled, family is not going to center on that patient, so we have to give family with that patient. We can say family have to centered on that patient. Communication, if any person is disabled in our home, then we are not going to communicate with him, like what are the things going on in his mind. If we are going to communicate with that person, then we know easily what are the things he needs emotionally, what he needs. I'm telling that about WHO definition, that health definition is there. In that, if we have to treat any patient at the mind level or mental level also, we have to treat. If any person is uh, feeling very low or we can say emotional, then everything, if we are giving like medicine or anything, then it is not going to work. If that patient is stable or mentally he is stable, that persons are very good, or according to our what we can say, that treatment, the nurses is going to give the treatment, but that nurse is not communicating properly. He's every time she is too much angry or anything. So on that time, that patient is also not feeling well. Maybe she is communicating good with the patient, then maybe that patient is good, and he is also thinking that that medicine is working on me. So then next, minority and marginalized population, complex care needed. Means types of care needed according to the person. Like palliative care is a care we are giving individually. One person's other person's body type is different, and the disease condition also different. But individually, if we are giving care to any family or any institution, it is going to be different. So complex care needs. Next, autonomy and dignity. And autonomy means respect. First, if we are giving uh, palliative care to any patient, so we have to respect that patient. If we are giving the respect and we are maintaining our dignity, that the patient is also going to take that care and things. 5, people with advanced chronic illness. Some people are suffering from advanced chronic illness. Symptoms, according to the symptoms, like cancer patient, maybe is feeling too much painful things, and what the things are going on their mind, it is also dangerous or anything. So we can give the treatment according to their symptoms. Health failure, that patients who are suffering from these things or family members are suffering, any person is dying by heart failure, so we have to give the support to that family, that person's family. Next, COPD or other conditions. Consideration of coordination of care. Like if we are working in any institution or in any hospital, we have to coordinate with our staff or the person who are working with us. Like if we are giving the care with the coordination, then we know the patient what they are feeling or what are the treatment is going on. Next, end of life planning. Like too much patients are there which are taking palliative care. End of life planning, like they don't have any hope to be live, but we are giving the care. So why we are giving the care? Because with the aim of that the last stage of their life, we can give a good and better memories. So end of life care, why we are giving? We have to make that things or that period beautiful and good. And homeless individual, if we are going with this 6, like homeless individual, what are the things we have to give? We are going to give our home to them. Why? We have to give because we are giving the palliative care. No. We have to assess to care, like what are the care are going on or services are going on, they are taking that services or not. If they are taking that services, then we have to aware on that. The second thing, psychological support. We can give psychological support and the services which is going by our government or some key principles of palliative care is there. First, holistic approach. Holistic approach means address physical symptoms and emotional, spiritual, and social needs. Holistic means we are giving the palliative care to the vulnerable group, then we have to holistic our care with the patient, family and caregiver support, involve family members and caregiver in discussion making and provide them with necessary support. Family and caregiver support means the family have to take a decision making with that caregiver person to support that patient, caregiver to treat their patient. Advanced care planning. Advanced care planning means according to the patient we have to plan what are the things we are going to do in advance. Like now what are the treatments are going on and what are the things we can do for that patient. So I'm going to summarize my topic. So the palliative, as I told that palliative care is an individualized care, yani ki, we are giving the care with the family members, like one family members and second family members. If we are giving, then individual we are giving the cares. Comprehensive symptoms management, like some small symptoms are there, we also going to give that management. Emotional and psychological support we are also giving in palliative care. Family and caregiver support, it is also coming in palliative care. Ethical and designation consideration, access to care. So conclusion is, if we are dealing with the vulnerable groups in palliative, we have to focus on that persons who are suffering from the things is going on in our society. With, I can say that community is there and elderly person is there, children are there. We have to focus on that persons and we have to give the individualized care according to the palliative care.
Thank you, Ms. Piyush. As this session is going to end for today, if anyone is having any queries, you can ask. Tomorrow we are going to start the session again on the same time at 9:30 a.m. So be available at that time. For today, if anyone is having any queries, you can ask for the session. If any student is having any doubt, they can ask the question from any of the speaker if they want.
Ma'am, my question is what the difference between palliative care and hospice care? Ma'am,
Okay, who will answer? Any of the speaker, if they want, they can answer this question. What is the difference between palliative care and hospice care? Any of the speaker who want to answer this question? So the question has been raised by the student, that was what is the difference between palliative care and hospice care?
good afternoon to one and all. It was a good session and it was a good question also from the audience. Have your seat. So if you are saying term palliative care is the care which is given to the terminally end patient. So it includes only physical, mental, social. If you are taking an holistic or hospice care, so it is going to deal with the more than that, the spiritual. So transformation of that particular, what we will say, self transduction bolte hai. So self transduction means we are going to beyond the level of physical, psychological, mental, and social. So we are going to deal with the spiritual to them. So whether that's what, as Ms. Piyush has been spoken with this vulnerable population, the marginalization, or if you are seeing a gender difference. So marginalization, which has been become the minority groups. So while we are considering, if I am a high grade in a religious based, or if I am having in a like subdivision wise, so no, I could not able to give the particular my I won't touch Bible, I won't touch Bhagavad Gita. Why I want to discuss this spiritualism? See, some of the persons who is going to die, they want to die with some good words. So like that only, okay, you're giving a more care towards the physical side and socially, but beyond that, they have everyone you should have to know, while end of life care, ear alone, that is hearing capacity alone, it won't dead until they are dying. So that's what that hospice care, which is going to deal with the as a nurses, we are going to use that. So while they are dying, we will be saying some words towards the spiritual life. So this is the two difference. Palliative care, just we are dealing with the physical, psychological, and social, and beyond that level, transduction ka we have to move on that spiritual. We have to consider as an human being as a whole person. That is what the hospice care. Hospice means whole human being. So without spiritual, it won't be fulfilled. So this is the difference. Any other questions? So
Okay, so we are ending this session for today. We will meet tomorrow. You can disperse now.